It's a major new initiative of the International College for Person-Centered Medicine and the World Health Organization Collaborating Center for Public Health Education and Training in the Faculty of Medicine at Imperial College in London. The formal launch will take place, but is taking place now. Here we are in Geneva. The aims and scope, well, basically there are three. Firstly, to debate and develop person-centered models of healthcare for specific clinical conditions. Secondly, to debate and progress the understanding of specific components of the person-centered care model. And thirdly, and they will be entitled, for example, they'll have a fairly generic title, for example, developing a person-centered model of care for the person with diabetes. In addition to the illness-specific conferences and publications in the series, there will be some topic-specific conferences too. And just to give you one example of these, in December of this year, hopefully in Rome, there will be a major conference on spiritual and religious care in clinical practice, which over the course of 2 intensive days will explore in great detail what we, rather historically this morning in this lecture theatre, looked at in broad outline, the relevance of a consideration of the spiritual dimension of man as part of a good clinical practice. The philosophy that underpins the series is really one which will aim to study, and this is obviously a situation where prevention has failed, and disease to some extent is manifest, to study how affordable advances in biomedicine and technology can be delivered to patients within a humanistic framework of care that recognizes the patient as a person and which therefore takes full account of her values, preferences, stories, cultural context, fears, worries and hopes, and which therefore responds to her psychological, emotional, spiritual and social necessities in addition to the organic and physical needs that the burden of illness exacts. What might typically be in one of these conferences, and therefore under the publications that will derive from them? Well, here are perhaps some 11 examples, but by no means exhaustive, just examples. Well, really to articulate the science, to look at where we are with accumulating biomedicine and technology. We will review current therapies and recent therapeutic advances and experimental therapeutics, the advances in biomedicine technology, the science of medicine. We will then look at issues such as person-centered integrative diagnosis, leading into a description of the humanistic framework, which is the context of the application of science in the care of patients, which we will therefore look at narrative, values and preferences, not mere theoretical iterations of the value of narrative and values and preferences, we know all about that, but looking at to develop methods which can elicit much better than we perhaps are doing at the moment, to elicit the narrative, to elicit the values, to elicit the preferences, and when elicited, how to use these sources of important knowledge within the clinical decision-making process. The conferences will clearly take an in-depth look at psychosocial care, and also a dimension of care that is often overlooked, but of extreme importance in conditions such as HIV, gynecological malignancies, prostate cancer, many long-term neurodegenerative diseases, and so on, psychosexual care. Cultural sensitivity will clearly be looked at. The person exists in society, and so social and environmental care, another overlooked dimension, will be looked at carefully. Spiritual and religious care, most certainly. Not then forget, after looking at the hands-on, as it were, elements of clinical practice, we mustn't forget the systems and setting, really, in which this optimal vision of medical practice will take place. So we'll need to look at person-centered medical informatics and information systems, how they may need to be modified and extended in order to collect and share information of relevance to person-centered clinical decision-making. Much of this model will require clinical service reconfiguration and redesign away from the fragmentation that we see now towards more integrated services in the delivery of care. And all of these things need to be implemented into new forms of clinical practice guidelines that do not continue simply to codify the effect sizes derived from randomized controlled trials and meta-analyses, but rather to do that certainly, but to bring in guidance about how to implement all of these other and use all of these other sources of knowledge alongside with the science in the care of patients. We may even decide to be slightly controversial and look at complementary therapies, since although they are outside of the biomedical paradigm, are being used by patients and patients seek our advice on them. These are some of the things that we will typically look at. The structure. Well, typically, given how difficult it is to get away for 3 or 4 day conferences and how expensive hotels are, particularly here in Geneva, as I'm sure you've all experienced, we are going to adopt a pragmatic model, which will be an intensive 2-day model beginning at 8 in the morning, finishing at 6:30 at night, with plenary and parallel sessions, rather than a more relaxed 3 or 4 days, so an intensive design, which will limit time away from work and limit the expense of hotels and all those other considerations. On many occasions, though, it has to be said, a 3rd day may be necessary, where if we look at the science and the technology in day 1, and we look at the humanistic framework in which it is to be applied in day 2, we mustn't forget the relevance of policy making and implementation of policy within health systems, and that may require a 3rd day or perhaps a half day. So typically, these conferences will be 2 days, but they may be 2.5 and sometimes even 3, depending on necessity. It's probably important to say, too, that within this conference, there will be a case-based symposium where a panel of experts will draw clinical cases from their own clinical practice and illustrate how the principles of person-centered medicine are applied in real clinical cases. The presentations will typically be 20-minute overviews, and the conference destinations will typically be London and Rome. This doesn't preclude other destinations over time, but we thought we'd start off in those 2 destinations which are very popular. And there will be 10 such international conferences per annum. Planning and advertising, boring but utterly necessary if we want to get people there to learn about these person-centered medicine. The conferences will be planned in terms of their academic content, and other issues of relevance to the operation will be determined by an expert planning committee, where email exchanges and assimilation of responses from email exchanges results in a draft which can then be circulated for subsequent refinement and agreement by the expert planning committee. The committee will typically be made up by formal nominees or experts from established international and European clinical associations and societies and patient advocate bodies and charities. So we're saying to these groups, send us your experts, send us your advocates to tell us how we can, and show us how we can get this thing right as part of this planning process. In terms of advertising, we would rely typically on the membership databases of the collaborating clinical associations and advocacy bodies and other databases as and when necessary. For example, I mean, I'll tell you a little bit more about this in a minute, but the first conference in the series on the 13th and 14th of September of this year is on dementia, and one of the societies to come on board is a fairly huge society called the Alzheimer's Disease International, and for example, ADI has 98, is the umbrella structure for 98 individual country Alzheimer's societies. So liaising not only in an academic sense with these bodies, but asking them to help us with the global advertising in this extremely thorough way would be very, very important to maximizing the number of delegates and therefore maximizing the audience which learns about person-centered approaches. We all know that when we attend a conference, it's enjoyable, but when it's over, it seems to be lost almost immediately in the past. We look in the diary and say, right, I'm somewhere else next week and the week after, and these things can get lost in the mists of time. So we aim to document in detail what will have been outlined in the conference. We'll document in detail in a special supplement of the journal what will have been presented in outline at the symposium in a special supplement of the IJPCM, and this will be guest edited by distinguished people working within the given area of illness. So that each 20-minute presentation will be written up as a between 3,000 to 5,000 word academic paper for formal peer review. We imagine that over the plenary and parallel sessions, which will be delivered over 2 days, we will have in total 50 presentations, which will mean 50 approximately 4,000 word papers, and so the special supplement will be approximately 200,000 words in extent. And depending on sponsorship, which we're fairly confident that we will be able to obtain, and I can say a little bit about that in a minute, we aim to make the special supplement open access online, so that as part of the international dissemination strategy, so that everybody globally, not just rich Westerners who can afford to download articles, will have access to this to plan their services. And even if they can't, for example, in the developing world, implement an ideal model of care, person-centered model of care in toto, they may well be able to identify, to implement it in parts. So it's very important that this special supplement is available, open access, and not funding permitting. You all know, I think, what the regular, and I must apologize to Christopher Woodhead, the publisher, for bastardizing volume 1, number 1 of the journal, to show you what the cover of the new journal looks like. We've done some playing around with design about how the special supplement cover would look like, and this is purely illustrative at this stage. And you can see that here we have the generic title, a descriptive title, describing what we're doing or trying to do, developing a personalized approach to the management of the woman with breast cancer. You see, again, in illustration, the logos of the functionally involved in collaborating society, the societies which help us plan the content via their experts and help us advertise via their databases. And we're carrying, this is just to show you incidentally, we've just given some thought to what the advertising flyer will look like, and the thing to mention here is that we are maintaining a sort of corporate design by taking elements of the logo of the International College for Person-Centered Medicine and carrying it over into the special supplement cover and the advertising flyer cover. In terms of funding, these things are not cheap, but they don't necessarily need to be very expensive either. If one is modest in terms of selection of venues, etc., etc. We anticipate that there will be 5 areas of funding for these conferences. There will be educational grants from patient charities, with whom I've had many conversations so far, which give me quite a lot of hope in this context. And it's very, very interesting that when I went to speak to 3 or 4 major patient charities recently, they said that strategically they were beginning to alter their funding slightly away from original biological scientific research, even by perhaps 5 or 10%, towards research into the care function. Because they said to me, what function is it? What part does it play if we are accumulating loads and loads and loads of information on biological and technological advance to commit it to library shelves, and none of it is going into practice, and every day we hear of scandals in the level of care in hospitals. Naturally, they were criticized by scientists who wanted research funding only to publish papers, to advance careers, but the charities are beginning to see that they need to do something else. They need to invest in scholarship as well as continuing to develop the fundamental knowledge base. Secondly, we anticipate that we will be able to attract educational grants from the pharmaceutical and medical technology industries, clearly as unrestricted grants of educational sponsorship and fully compliant with the established ethical and regulatory frameworks. Certainly in the UK and increasingly elsewhere, national health services are being provided by private healthcare companies, being commissioned by National Health Services to provide care within National Health Services from private providers, and several of these, for example, Bupa and Spire, and indeed one which has just been set up by the entrepreneur Richard Branson, which is entitled Virgin Healthcare. These people are very keen to support initiatives of this type. There will always be individual philanthropists where they can be tracked down and cornered. And there will be health foundations too. For example, the project we hope to do on spiritual and religious care, we are appealing to the Templeton Foundation in the United States to fund that work. So there are 5 typical sources of funding. How do we determine the topics? Right, well, the topics will be determined finally by the board of the International College of Person-Centered Medicine. What will be the rational basis on which those topics are identified and confirmed? Well, there are several such bases. One of them, for example, might be the World Health Organization priorities set out in the Global Status Report on NCDs in 2010. There are other sources of illness-specific areas to look at will be suggestions by government and suggestions by patient advocacy groups. As a rule, the conference will focus generally on long-term chronic illnesses because that's where person-centered medicine is at its most powerful. And we are at a situation of emergency, an odd thing to say, but now recent data shows that nearly almost 70% of global deaths internationally are due to chronic diseases. So we are confronted by a health services emergency, which can be addressed in part by this approach. What have we identified so far using this rationale? Well, dementia, as I mentioned earlier, which is scheduled for 13th and 14th of September in London. HIV/AIDS, which is scheduled for 20 and 21st of September, again in London. Parkinson's disease, 24th and 25th of October. Prostate cancer, 29th and 30th of November. And we're currently determining the dates for breast cancer and diabetes. The topic-specific conference on spiritual and religious care will be in December 2012, probably towards the end of the second week of that month. Others to be considered by ICPCM will be, for example, chronic respiratory illness, chronic cardiovascular illness, person-centered care of the older person, person-centered care of the child and family, any number of a range of neurodegenerative diseases, mental health, and other topic areas, maybe shared decision-making in clinical practice. What is it? How is it done? Especially in light of some vigorous discussion we had in this lecture theatre only yesterday. I'll talk to you now a little bit with some specificity about the first of the conferences, dementia. This is supported academically and through advertising by three of the biggest dementia organisations in the world who've confirmed involvement. Alzheimer's Disease International, I mentioned earlier, which has 98 individual country members and an enormous editorial, an enormous scientific and medical advisory panel and an enormous membership. The International Psychogeriatric Association, the IEPA, which is a smaller society of some 1,200 physicians, but physicians who are at an extremely high level of distinction in their field. And Interdem, another major, largely European-based, but it has international connections too. So these are the specialist societies which give us their academic input and advice to the symposium, in addition to helping us with the operational aspects of advertising. We're very pleased that other societies already involved with the International College have confirmed, as it were, a general, generic support of these initiatives. And one of these is the World Medical Association and the World Federation for Medical Education, for example, and the International Association of Patients, or Alliance of Patients Organizations, and others, which we hope and believe will say yes, are currently to write to us to confirm involvement, such as the World Organization of Family Doctors, WONCA. Finally, before handing over to the next speaker, the Expert Planning Committee, which has been formed according to the method I described, the membership so far is shown here. We are awaiting the identification of another 6 or 7 experts from those parts of the world which you cannot see here at the moment. When we have those nominations, and I'm hoping that when I get back to London on Wednesday afternoon, I will have those people. When I have those people and they're added in, the Expert Planning Committee will begin its work, and experts, as of the nature of being an expert, I suspect that well before the end of May we will have an agreed programme with which to proceed to advertising via the membership databases and via the new website, details of which will be presented in due course.
Thank you.